of InternetMedicine.com, broadcasting from Miami. Tonight we have a presentation of Dennis Thompson, CEO of ARP Wave device. He's going to tell us about his device. And we're joined by two guests, Alex Badia MD and Eric Ryland from North Carolina. So good evening, gentlemen.
Good evening.
Okay, first we'll start with you, Alex. Could you introduce yourself and tell us why you're here tonight?
Yeah, I'm Alexander Badia. I'm an orthopedic hand surgeon and the founder and the chief medical officer of Ortho Now, which is a unique orthopedic urgent care franchise, which provides certain orthopedic technologies and treatment protocols to patients who come to us on a walk-in basis. One of those treatments is an extremely novel device to the general public, although well-known amongst elite athletes, which is called ARP Wave. Stands for Accelerated Recovery Program. It's basically a neurotherapy that really treats the origin of pain and has a variety of mechanisms of action, including improving perfusion or blood supply, which accelerates healing, decreases pain and inflammation, improves range of motion, and really helps me with my own patients even post-operatively. So we're really happy to have the one of the co-inventors of this technology with us today.
Well, welcome, Alex. Eric?
Yeah, well, I'm Eric Ryland. I'm the Vice President of Franchise Operations for the Ortho Now Franchise Network. And I am based in North Carolina, but I'm able to do that because our headquarters is in Doral, Florida, a suburb of Miami, but we're a national and soon-to-be international company. So we kind of have our team spread out about the country.
Okay, welcome, Eric. Okay, Dennis, the show's all yours. I guess you'll tell us about your device, and then we'll open it up to questions. Welcome.
All right, thank you, John. My name is Dennis Thompson. I'm the CEO, as Alex said, of ARP Wave. And what we are is not an equipment. Think of it as a new therapy. When I say physical therapy to everyone, they think of therapy in general. It could be a variety of different methodologies, but it's therapy. That therapy addresses the pure physiological side of the problem. Example, if you have pain in your knee or pain in your wrist or you have a torn tendon or ligament, everyone knows where the problem ended up because we have diagnostic tools to tell us that. We have scans, we have x-rays, we have MRIs. What we don't have until now is a way of identifying where that problem actually came from. Not where it ended up, but where it came from. So I tell all my patients and all our providers, think of the body as a computer. And the computer has two distinct components, like the computers we're on tonight. The first component is the hardware. The second component is the software. I submit to you that the overwhelming majority of people in modern medicine worldwide, and we are an international company, address the hardware problem, not the software. And the software is the nervous system, which drives absolutely everything in our body. So as an example, if you're an athlete and you've been trained all your life with weights and resistance training, the one thing you've never trained is your nervous system, which controls those mechanisms. If we're a surgeon like Dr. Badia, he's trained on how to repair that damaged tissue, and he's an absolute magician at doing it. But he'll tell you that, and every doctor listening knows, that a byproduct of surgery is going to be post-surgical contractures and atrophy. Now, I'm a physiologist by education, and every time I would ask myself the question, why do we have atrophy, and why do we have post-surgical contractures? Why does it take so long to come back from an injury? Why does it take so long to come back from a surgery? I could never answer that question in a pure physiologic manner. The second I turned that coin over and looked at the neurology of it, it made perfect sense. So as an example, when we're doing surgery, we're creating a neurological disturbance. Unless we basically repair that neurological disturbance and get those muscles to fire the way they fired previous to the surgery, we're going to have atrophy. And we have atrophy worldwide. We have a double-blind study which shows that we can eliminate atrophy by simply getting the muscles to neurologically fire the way they did previous to the injury or the surgery. So we created a therapy called neurotherapy. It is a supplement, not an exclusion of, but a supplement to physical therapy. So a physical therapist is fighting a neurological signal. So Eric, let's say that you broke your arm and you're in a cast and you're in a sling and you're in that cast or sling for 6 weeks or 7 weeks. And then the doctor pulls the cast off, takes you out of the sling, and your arm is still in the same position it was in the sling. So now you have to go to physical therapy, and the physical therapist's job is to get your arm into extension. Now that therapist could be extraordinarily gifted, but he's fighting, or she is fighting, a neurosignal which says, I'm supposed to be in this position. With our technology and our therapy, in 1/16th of a second, we change that signal, and the muscle now, in this case, would be the tricep, would go into full extension, and the arm would go into full extension. Then we have to train the muscle neurologically, not physiologically, on how to stay in that position, because that is a neural pattern. So every patient seen by any doctor for any reason has two things, and it doesn't make any difference what the indications are. The two things they have is a compensation pattern, and they have a nervous system which is not firing a fast enough signal to the appropriate muscles to do the appropriate job at the appropriate time. Otherwise, they wouldn't be seeing a doctor. So all the doctors listening, this is a supplement to everything that we're presently doing. So a patient comes in with any indication whatsoever, if it's pain, restricted range of motion, if it's atrophy, if it is a stroke, spinal cord injury, sports injury, any type of fracture, that patient is in a neurological pattern that we call sympathetic dominant, which means they're in protection. So the muscles are going to be concentrically contracted to support that patient, to protect them. It's very difficult to treat someone who is in a protection mode, as we all know. What the ARP system does is it utilizes a tool as a diagnostic medium to find out exactly where the signal is coming from that's causing the physiological symptoms that are being evidenced in front of us. Once we know where the signal is coming from, we can address the appropriate muscles, the appropriate nerves which innervate those muscles, to retrain the muscle, to break the pattern of movement that they're in, and break the cycle of pain or break the cycle of movement dysfunction. It's all about neural training. It takes 20 days to completely disrupt an old pattern and create a new pattern. That is what we do. So a patient comes to us, they'll have pain of say 8 or 9, and Dr. Badia has seen this time and time again, and they have restricted range of motion. We'll go and we'll identify, is the nervous system working? We do that by a simple test. That test identifies is the system sending a fast enough signal to the antagonist muscle to allow the patient to absorb force. And what I mean by absorb force is Dr. Badia and all of us trained in any type of medicine look at strength as a singular component. Like John, you're looking at strength as the ability to perform a function or have a resistance load or functionality. We do not look at strength, the other side of that component, and that is the neurological component, which allows that muscle to absorb force. Because the second that muscle can't absorb force, that force transfers to tissue that we don't want it to go to. Tendons, ligaments, fascia, and bone. If that muscle is neurologically firing correctly, that never happened. 95% of the people listening right now would fail a baseline neurological test, which indicates they're either already hurt or going to get hurt, one or the other. So the athlete, we can drastically reduce the number of injuries we have in athletics. We have 2,000 of the most elite athletes in the world. Our players do not get the traditional injuries that we experience in athletics. Tendons, ligaments. What's the #1 injury in all of athletics? Tendons and ligaments. Why? Force is going to that tissue. It's supposed to be going to the muscle, but the muscle's never trained to do it. So in the therapy, what we're doing is we're training the muscle to have a rhythmic dance between the agonist and the antagonist. And that is the clearest, cleanest definition of athletic performance there is. It also is the clearest definition of human movement. Because if you have one muscle fighting another, you're not going to have fluid movement. Anybody in pain is not in fluid movement. We all know that. What we don't address is the neural component of that movement. What this technology allows us to do is retrain them neurologically to break a neural pattern, to get them out of the pattern they're in. Whether it's pain, restricted range of motion, makes no difference. They're all a pattern. And until you break that pattern, we're not going to make a facilitative change long term. We're going to make short-term change, of course, but we're not going to change the program. We're not going to change that pattern. So every doctor now has the ability to have a tool where they can identify where the origin of the problem is, first time ever. We now have a tool which can, not they do it, but an MA or a staff person trained by us, they can now offer that patient neural therapy. It's covered by all insurance, and we have two distinct revenue streams for all the doctors. Revenue stream 1 is therapy. Revenue stream 2 is durable medical equipment, where the patient actually has the device at their home for 6 weeks, sleeping with it, getting 8 hours of reinforcement neuro training while they're sleeping, increasing blood supply, moving force out of the area. So John, as an MD, if I ask you, is it possible to speed up healing? The traditional answer to that question is what? No. Is it possible to slow down healing? The traditional answer to that question is yeah. We can retard it, but we can't speed it up. What speeds it up is treating the nervous system, the central focal point of the problem, not the problem. And we're training doctors all over the world in this technology, and it's so exciting, and it's so exhilarating. I mean, Dr. Badia can share many stories with you. I could share hundreds of stories with thousands of stories where we can dramatically change the quality of life of absolutely any patient with any indication. Not because it's a panacea, it's because we're working on the origin of the problem, not the problem. Any questions?
Yeah, thank you very much, Dennis. Alex and Eric, do you have questions, comments?
Well, this is this is a really paradigm shift in thinking. As an allopathic physician, one has to open their mind
No question.
What's really difficult about this from the traditional medical point of view is it's very hard to understand the physiology, how it really works, because as physicians we want to try to break it down and think of it, but really when you experience it, and I did, and the reason really a lot of this came into being before I even met Dennis is my tennis coach, who was a patient of mine for a brief time. I wanted to learn tennis because I treat a lot of pro tennis players, and I felt I should learn. And first time I got on the court, I mean, I sprained my hamstring, and it happened a couple times in a row. And Matthias Polanski at the Polanski Tennis Academy, who was previously a top-ranked player from Argentina, put the ARP wave on my hamstring, and within minutes I was able to really almost palm the ground, and it really lengthened. You could feel it really would lengthen and relax the semitendinosus, semimembranosus, really what we call the hamstrings, and we then started incorporating this into some of our treatments, and now it's just a mainstay. Basically, when patients come see me, if they don't have the mechanical problem that Dennis spoke, meaning they don't have a rotator cuff tear, I mean that needs to be repaired.
Absolutely.
It's just pain, inflammation, the muscles in spasm. That's why people say, they use the word knots. I have these knots here, this spasm. Yeah, you can take anti-inflammatories, but we know all these things have side effects, and when they don't work, this is a technology that really relaxes this and changes the patient experience. And when you experience it, when you see your patients experience it, you realize this opens up a whole new world of treatment that previously we, as surgeons, we would just order therapy, give them medications, a lot of times just refer them to a pain management specialist or something like that. But now we actually embrace these patients because we know that we're going to get them better. So it really is exhilarating.
So one question, Dr. Badia, you find that it shortens recovery time generally?
Oh, absolutely. Well, Dennis mentioned that one of the things it does is because everything is controlled neurologically, right? So blood flow is controlled, and if you affect the nervous system, it can vasodilate, vasoconstrict, and it's been shown that you can improve blood flow, dramatically, to the point where you can accelerate the healing of fractures. In postoperatively, we find that the patients have much less pain. We think it actually potentiates the block that the anesthesiologist puts in. So he does, for my shoulders, we do an interscalene block. We think it not only potentiates that, but it seems to perhaps draw fluid out of the joint, because that's an ionic mechanism, and it's a neurologic process as well. So the patients have much less swelling, and they have much less pain consequently. So it's pretty dramatic.
Dennis, do pro athletes use this a lot? It seems to be. You treat the Minnesota area athletes?
Absolutely, John. We have approximately 650 NFL players that we have as clients. We have about 385 National Hockey League players. We have about 100 NBA players. We have over 1,000 soccer players from all over the world. We have the top players in every sport you can imagine are clients of ours. If you go from tennis to swimming to basketball to football to hockey to track, you can't name a sport where we don't have the top athletes in that. There's a reason for that. And that is because we're able to extend their career, increase their overall ability to demonstrate the skills that they have, but they don't have the physiological ability to do it presently. Example, John, when you were smaller, when you were 2 to 3 years old, you had a lot more suppleness than you do now. And the answer is, there's a question, the bigger question is, why? And the answer is, we created the pattern of movement that we're presently in right now. That doesn't mean that is our ultimate movement pattern. It just means it's the pattern of movement that we're in now. In seconds, I can change that pattern of movement by allowing the antagonist muscle to go to eccentric contraction while putting you in a movement that accentuates that contraction. And you will have an instantaneous change in range of motion. So let's say, John, let's say you have a fibrotic knee. You're locked at 90 degrees. You can't get beyond 90 degrees. The muscles are just, they're spasmed. If you relax that muscle, the antagonist muscle, which in this case would be the hamstring, you're going to increase the range of motion instantaneously. That's what we do. But then if you take it to the performance side, look at the one question I ask every single athlete, no matter what level they're at. How long have you been playing that sport? So if I asked Dr. Badia, how long have you been playing tennis? He would say X amount of weeks, months, years. How many times a day do you practice that? Or how much time do you practice that? Then you ask the $64,000 question. Did you spend the same amount of time preparing your body to perform that task? And the answer unequivocally is no. So every athlete at every level has a capped ability based upon the muscle's inability to demonstrate the skill sets that they have. I go to the NFL Combine, I can take a guy that does a 4.440, put this device on him prior to running, and his 4.440 is 4.3. That's millions of dollars difference in the NFL draft. Did I make him faster? No. All I did is relax the muscle his brain cognitively could not do on its own. Now you take that and move it over into therapy, and you look at arthritic patients. What's the number one problem we have with an arthritic patient? Movement. So if you put them into physical therapy, it compounds the problem. Why? Because the joint is where the force is going. All I do with neurotherapy is transfer the force out of the joint into the muscle where it should have been going all along, and then retrain the patient without movement, without irritating the joint, and now we have the best of all worlds. They're caught between a rock and a hard spot. They can't do what they need to do to get better. They can't exercise because it hurts, and the only way they're going to get stronger is exercise. So they're caught between a rock and a hard spot. We allow them that opportunity. You know, we're talking about chronic pain, like CRPS or fibromyalgia. Look at that as like Dr. Badia said, I'm asking people to look in a different paradigm. What if we're looking at pain wrong? John, as the MD, what if we're looking at pain as, instead of an overexcitation of the nerve, what if it's exactly the opposite? What if it's an underexcitation of the nerve? And we're treating it, we're ramping down that impulse. Look at how we treat CRPS and fibromyalgia in the medications that we use at our disposal. And we still have chronic pain. I submit that chronic pain is a neural pattern, and we can break the pattern, treat them neurologically, not pharmacologically, and not physiologically, train a new pattern of movement, and train and in turn train the signal. We all have seen internal modulation from like Medtronic and people like that, where that signal goes in and it disrupts the other signal, and so we have little pain. It does not neurologically retrain. That is the downside. This therapy allows us that opportunity to neurologically re-educate that patient, neurologically break the pattern. Once we break the pattern, now we create a new homeostatic pattern. That becomes the norm, not the old pattern. To do that takes years, because you have to, in chronic pain, you've got to override that signal. That signal's coming in at 2 times a second. If I send a signal in at 500 times a second, I'm going to win that race every single time. So I just send in a different signal. That becomes a homeostatic signal. Does that make sense, John?
Yeah. Well, you know, I guess a huge problem, low back pain. Does it have a place in low back pain?
Tremendously effective for low back. Think of it this way. We've treated well in excess of 90-some-odd thousand patients with better than a 95% success rate. Success rate identified by pain level of 10, 9, or 8 coming in and leaving at the end of 20 sessions at a pain level of 1 or 2. So let's talk about back pain, John. You brought it up. The back is not the problem. The back is where the problem ended up. So in almost every single back case I've ever worked on, and my staff has ever worked on, the problem traditionally is in the legs. So think of it this way. If you're a house and you're built on stilts and the legs are the support, the stilts, and your upper torso is the house, and you cut the stilts out from underneath the house, what happens to the house? It collapses. So the reason we have so much back pain is watch, and you can see it happen daily. Watch how somebody gets out of a chair. The first movement of coming out of a chair is forward tilt. The second movement is bending the knee above and below, beyond the ankles. So the point of force is going into the knee and it's going into the back. So we're sitting like this, coming up out of a chair. All the force is right here. So if I can transfer the force out of here and put it into your glutes or your hamstrings and keep it out of your back, are you going to have a back problem? No. But we can't do that because the brain is geared to protect us. And so we go into all these protective mechanisms, and the medication that we take basically hides the problem but does nothing for the problem. And now you got 2 other problems. You got atrophy because you've changed your range of motion, you've changed your pattern of movement, you've changed your activity level. So you got atrophy, so you begin muscle wasting. Now you go into a deeper compensatory pattern. It feeds the sympathetic dominant nervous system, and now you have chronic back pain. When all you need to do, John, you'd be utterly amazed. Forget the ARP for a second. If I just had a patient get up out of a chair correctly, and I'm holding them, and they push their feet into the ground and their torso doesn't come forward, 90% of the back patients are going to say, I don't feel anything in my back. The trouble is, they can't do that. And no amount of physical therapy is going to get them to do that. And no amount of shots are going to get them to do that. You've got to neurologically retrain those muscles to transfer the force out of the damaged tissue. Bone on bone, same answer. We're bone on bone because force went to that joint. It's impossible to be bone on bone if the muscles are working correctly. So we got the best doctors in the world, the best therapists in the world, best strength coaches in the world, and we still have chronic pain, we still have atrophy, we still have bone on bone. It can't be physiological. And the only other thing it can be is neurological. And I've had many neurologists. One of Dr. Badia's best friends gave me the greatest compliment I've ever had. He said, you're shining a light on a subject that absolutely none of us have ever been trained in, including neurologists. They're not trained in the neurology of injury, the neurology of surgery, the neurology of rehab. They're trained in the neurology of disease. And that's what's so exciting about this, is we can facilitate a change to so many people in such a large patient population.
One general question, Dennis. Is this device indicated for immediately after the injury, or you kind of wait, work up the problem to see what it is, and then use it?
No, we were extremely successful with either chronic or acute, or just fresh injury. Example. I've talked to the National Football League many, many times, and in the conversations, I will always say, we always blame athletic injuries because the athletes are getting bigger, stronger, and faster. That can't possibly be accurate, because if that was the case, every single time an athlete would get on the field, they get hurt. That's not the case. The case is that if I walked into any athletic organization in the country right now, any place in the world, and I gave them a simple neurological force absorption test, 95% of them are going to fail the test. That means that we're not neurologically trained to do athletics. We're not neurologically trained as just a common person, non-athletic. We're just not neurologically trained. Did anybody ever teach you, John, how to sit?
No.
Stand?
Sometimes.
Walk? Run? We're not taught those things. So how in the world are we going to learn how to do them? You know, the only people that know how to stand and sit correctly are 2- and 3-year-olds. They don't know how to do it wrong. My research indicates that past the age of 4 years old, we pick up the habits of our environment. And when we pick up those habits, that's when our breakdown of fluid movement changes. The Russians figured that out. I just took it one step further.
Very good.
I'd like to address the question that John had about acute injury. I'll give you a scenario where a week ago I sprained my ankle. Actually, on my boat, I was barefoot. I slipped a little bit. I could feel the deltoid ligament on the inner aspect, medial aspect, tear immediately. Didn't swell a lot. I iced it right away. So it was either ice from my drink or for my ankle. And I opted for the ankle, and certainly I kept control. But I'll tell you, it still hurt a lot. So to the point where I was actually limping. The next morning, I took my kids to school, and I just shoot them out of the car, because normally I like to walk them, but it was daunting just to walk a couple hundred yards. I'm thinking, how am I going to see patients? Because I got to walk between rooms very fast. You know, I knew, like usual, ankle sprains heal, but I thought this is perfect for ARP. Sure enough, that later that day, Matthias put my foot. Actually, Trent treated me that day. Put my foot and ankle in a bucket of water. Put the electrode under the ball of my foot. Another electrode was on my ankle, and I could, you feel the current, and I'm turning the juice up, and I felt like there was a constriction, and I felt like any of the edema I had was gone, and I came out of that about 20 minutes later, no limp, pain was gone. I mean, it was remarkable, and I know that, there's high-level names in the NBA, which we might not be able to use, but I know have been able to play right after an ankle sprain like this. We did it to CrossFit. We're going to have ARP. We did it last year. We're going to have ARP waves right at the Waterpalooza, which is a big CrossFit games. These guys, one guy I know tore his pec. He wanted to continue competing. We put it on him. We relaxed it, and I didn't really recommend that, but he was able to compete. That's just an anecdote from myself. It's really remarkable.
Yeah, I'm sure sports teams must love it.
Well, that's what's happened exclusively.
Players do.
Yeah.
That's it's an interesting statement you just said. You would think the teams would love it, but it's perceived as something from the outside, and there is a lot of protection of the players, et cetera, et cetera. Our players, one of the biggest stories in the Super Bowl when the Colts, Indianapolis Colts, played the New Orleans Saints. The biggest story of that Super Bowl was, is Dwight Freeney going to play with a grade 3 high ankle sprain? That's a 10-week recovery, 8 to 10 weeks, normal. We had an MRI immediately the week prior to the Super Bowl, showed a complete disruption in the deltoid ligament. 6 days later, he got clear to play in the Super Bowl and had no more tear. Now that's not magic. That's valid empirical data from the Colts, and he had a sack in the first quarter. He would have never, ever had that opportunity had it not been for us working with him neurologically, not physiologically. Not once did I go near his ankle.
Very good. Well, Dennis, I think we'll wrap it up and let you guys get some rest. Thank you very much for the presentation, and thanks, Alex. And
yeah, I just wanted to mention that everybody can see this live and in person at our event on January 27th. It's a week from Tuesday at the Miami Anatomical Research Center, the Mark Center in Doral, Florida, where we're having our Fit Triathlete event. So this will be our first annual event, and Dennis and Dr. Badia will be on the panel that evening as well. But we only have one of the reasons we did this tonight is we only have 6 to 10 minutes per topic on the night of the event, so we wanted to go a little more deep dive into it. But we're also going to have a setup of ARP Wave in the lobby of the center, and so people are going to be able to see it and even try it in action.
Yeah, I made a rookie mistake. I really didn't introduce the series. Actually, this is one in the series of pre-symposium hangouts, which does, as Eric says, lets us go into depth in more areas.
We should be sure to mention that in the remaining hangouts that we have, because we do have 7 or 8 more of these to come over the next 10 days.
Yeah, and they'll be on the Internet Medicine /Ortho Now, and I guess you'll have them on your site too, right?
Yeah, the schedule's on fittriathlete.com. There are a bunch of ways you can get to it, but that's one way. And then orthonowcare.com, we have a whole page about Fitness Month. January's Fitness Month at OrthoNow. Okay. And we've got a page devoted to that.
Any closing remarks, Alex?
No, I'm really happy that we encountered this technology, and it's not even a technology. I know that Dennis doesn't like that term. Obviously it is, but it's really a protocol. It's a treatment system, and
correct.
We're really proud that OrthoNow has the opportunity to bring this to the public, because when you asked about the elite athletes, we feel pretty strongly that everybody should have access to this, and that's what OrthoNow's goal is to make orthopedic care very accessible to the public. Our VP of Sales calls it orthopedics on demand. And that's what OrthoNow hopes to do, and ARP Wave is one of several treatment protocols that we offer.
Very good. Okay, gentlemen, we're going to stop the broadcast and then just hang around with the chat a little bit. So good night, everybody.